My name is Tariq Al-Madoun. I'm a neurosurgeon at the Spinal Hospital. And our topic tonight is scoliosis. We have an introductory lecture, and we organize it for the first time. I hope in the future we'll go for advanced lectures for seniors and masters in spine surgery. Whether you are a physiotherapist or a neurologist or a GP, you will see in your clinic patients with spine deformity and scoliosis, and definitely an early diagnosis and early management will play a significant role in the life of your patient. I am pleased to introduce my colleague, Dr. Antony Michael, who is an expert in spine surgery, an expert in the deformities and scoliosis surgery. And he is a consultant spine surgery who has been working in the United Kingdom at the Sheffield teaching hospitals for many years. And he recently joined us in our hospital. And I'm pleased to introduce him to share with us this information about this important pathology. After this presentation, we can take some questions. If there is any burning questions, we can interrupt him during his talk and address him these questions. He kindly agreed about that before for that chat with him today. Please, Dr. Michael, welcome, and all of you join me in welcoming Dr. Michael, please.
Hi. Thank you very much, Dr. Tariq, for the lovely introduction. So welcome to all the delegates who have kindly joined us today. I wanted to thank you for taking the time out. I am very passionate about scoliosis, the early diagnosis by screening, appropriate management, and if required, then surgical treatment. You will all be aware that June is the Scoliosis Awareness Month, and a couple of days ago we had the Scoliosis Awareness Day. There's been some social media posts about all of this. So essentially this talk is started as an introductory session to scoliosis. I've spoken to several GPs, physiotherapists, orthopedic surgeons, orthotists who are all passionate about the management of scoliosis. And I think a joined up plan will be good. And I'm hoping that we will start some networking and communication in this regard. So as Dr. Tariq said, I'm Dr. Michael. I'm an orthopedic spine surgeon, currently working at the Neurospinal Hospital in Dubai. So in terms of conflict of interest, there's nothing really with this talk, but I do have a teaching contract with Dupuy Synthes Spine and Stryker Spine in the UK. And also just to let you know that some of the images are subject to copyright, so please do not make any individual recordings of any of the images. You will note that the video per se, the webinar is being recorded, and we will be posting the link to this recording on social media and at request. So I want you to ask a lot of questions. You can use the chat function on Zoom. Dr. Tariq will be kindly monitoring all of these chats, and I've given him carte blanche to interrupt me at any stage with questions, because I think an interactive talk would be much better. So please feel free to use the chat function. You can ask any question that you like, and if I know it, I will answer it. If I don't know it, I'll find out the answer and get back to you. So according to the DHA guidelines, you will know that we have one CPD point awarded to this webinar. They are very strict. What they have said is that if delegates attend the whole webinar, at the end, they will be awarded the certificate. So at the end of the webinar, we will send you a questionnaire about how you thought about the webinar. And once we receive the questionnaire back, we will be sending you the certificate with the CPD point. So what I would like all of you to achieve, if you don't know already, is that you should know what is scoliosis. So the definition per se, you should understand that there are different types of scoliosis. I will try and emphasize the importance of early diagnosis. And we will talk about the options for non-surgical treatment and also some surgical treatment. And I'll try and finish off with some recent advances in both. So as you can see, this is a vast topic. We will try and go through it as much as possible. So just to set the scene, you may or may not be familiar with these appearance on X-rays, where you see a curve in the spine. You see the patients will have asymmetry in their trunk. So that is essentially what we're talking about. So the definition of scoliosis is fairly straightforward. From the olden days, it's been defined as a lateral or a sideways curvature of the spine. More recently, we have appreciated that this is a three-dimensional deformity of the vertebrae, but also affects the soft tissue, it affects the discs, the ligaments, the joints, so all of them get abnormally orientated, and you will know there's a significant rib deformity. But at the level of a functional spinal unit, the vertebrae will tilt, rotate, and translate to produce these asymmetry and change in shape of the spine. So we are used to looking at X-rays in two dimensions. So there will be a coronal or a front to back curvature. And sometimes in the sagittal plane, there is a abnormal curvature, which sometimes is difficult to appreciate because the rib cage makes it difficult for us to know exactly where the spine is. But the conventional thoracic scoliosis will produce a flattening of the normal kyphosis because it's rotated into a different plane. So I often get asked by patients and their parents, why do I have this? Or why does my child have this? What have I done wrong? What have they done wrong? And essentially, there are two simple answers. One is, I don't know. And two, it is due to an underlying issue that we can diagnose. So the primary, or what I call idiopathic scoliosis, there is no unidentifiable cause. Even though if you dig deep down and maybe do a genetic profiling, you may find some gene mutations. The secondary ones are easier. There may be very obvious causes like cerebral palsy. There may be obvious syndromes, or it may have a congenital basis. So that's the main cause in terms of etiology. So coming on to idiopathic scoliosis then, there have been some ways of trying to classify or get more information about the scoliosis. Now, the earliest grading, if you like, that I was familiar it was infantile, juvenile, and adolescent. And the infantile was from birth to 3 years of age. 3 years to 8, 9, maybe even 10 years of age was the juvenile, and anything over 10 years of age was classed as adolescent. Now, the importance of this is, in my eye, the infantile ones may be due to a syndromic or a congenital cause, so we need to be very careful to call them idiopathic. The juvenile ones are very important because they're by far of idiopathic cause, but the management is very tricky because some of them can progress very rapidly and some of them can cause compromise of cardiorespiratory function very quickly, otherwise called a thoracic insufficiency syndrome. So this diagnosis is mainly based on the age at the time of diagnosis. Now, the Scoliosis Research Society have made it a little bit simple by calling it early onset from birth to 9 years of age and late onset from 10 years of age and above. So I'm just going to briefly talk about how do we find out whether a patient has scoliosis. So it's easy if they walk into your clinic and say, I've got a curve in my back. Sometimes you may find it on incidental examination for something else. But once we suspect or diagnose a scoliosis, it is very important to get a thorough history, do a systematic examination, carry out special tests maybe. And then the definitive diagnosis is by X-rays or radiographs. We may want to get more information with MRI scans about the spinal cord, spinal dysraphisms, etc. And sometimes we want to know the bony anatomy a little bit better, and that is clearly with 3D scan, CT scans with 3D reconstructions, etc. So what are the important points in the history? Well, it'd be nice to know who actually picked up or noticed the curve, because this is the person you want to ask whether the curve has progressed. Now, I'm often told that it's the parents who picked it up, sometimes friends, teachers, especially swimming coaches, gymnastics coaches can pick it up, and occasionally GPs pick it up when you take the child for an unrelated condition, maybe a chest infection. So in the history, it's very important to know how it has been over the last few months or the last few years, because this will give us some idea about how the curve or the curves are going to behave as we go forward. Developmental milestones are very important because this gives us an idea as to where the child or the patient is in regards to their skeletal maturity. The skeletal maturity is very important because it's well accepted that if a child is skeletally mature and still growing, then the curve can progress and get worse. So at this point in the history, it's very important to exclude what we call red flag symptoms. So red flag symptoms are things like severe pain at night, which is unusual in idiopathic scoliosis, a fever, loss of weight, history of cancer, and these sort of things, which makes you think, is there something else going on with this patient rather than just an idiopathic scoliosis? It's also very important to know what treatment the patient has had in the past, because that will determine how we treat it in the future. For example, if someone has already had years of bracing, then we may think, well, bracing is not going to work. Okay, at this point, I'll just ask Dr. Tariq if there are any questions.
Yes, I would like to ask you regarding familial scoliosis. We've seen many patients who have siblings with the same condition, like 2 or 3 brothers or sisters, they have scoliosis. From your practice, can you tell us about this more?
Yeah. So that's a very good question. In fact, I deliberately left out the family history on this slide, hoping that somebody will pick me up on this. So the family history is important because, as I said, there is a strong theory that there is a genetic component to the causation of scoliosis. In fact, there are genetic tests which claim to predict how severe the scoliosis will be. So knowing that the mother has had it, or a sister or a brother has had it, or a grandmother has had it, gives us very good indication as to how this scoliosis may behave. I mean, I've had patients whose mothers have had Harrington rod type surgery for their scoliosis. And then the children have typically behaved in a more progressive fashion and required surgical treatment. So that is a very important historical point to elicit. So in terms of how we further quantify the scoliosis, we need to examine in a very systematic way. So I usually start off by asking the patients to walk. And this gives you a very good idea about their balance, their gait, is there an element of pain or an antalgic gait, etc. We then focus on an adequate exposure of the patient, preserving their modesty. I would always recommend that these patients, even if they are with their parents, are examined in the presence of a nurse. So we're looking for trunk asymmetry. Starting from the top, is the head centered over the pelvis? Is the shoulder level, or are they both at the same height? What is the degree of prominence of the scapula and the rib cage? I usually don't like the term rib hump. I know it's a very well-established term, but I always say rib prominence or scapular prominence rather than using the word hump. And similarly, in the waist, you can get what we call a loin prominence. And again, I call this a loin prominence rather than a lumbar hump or anything like that. So we know that there's a rotational abnormality, so we can get focused on the back, but we also need to check the rib cage for any asymmetry. And oftentimes, patients will be unhappy with the prominence of the rib cage on the left side in the front and prominence of the shoulder blade in the back. So trunk imbalance, and then you look for any sequelae of underlying diagnosis like cafe spots you can get in neurofibromatosis. Sometimes in a spina bifida, you can get a tuft of hair or pigmented patches in diastematomyelia, which is where there may be fibrous or bony partitions of the spinal cord. Secondary scoliosis is, again, as I said, fairly straightforward from the point of view of examination. You can see all the sequelae of cerebral paralysis or muscular dystrophy, spinal muscular atrophy, and various other neuromuscular diagnoses. Syndromic scoliosis may be a little bit more difficult to pinpoint, but most of the time you get a clue that there is some underlying diagnosis here that we should not miss. For example, typically Marfan syndrome, you know all the hallmarks of that. There are dysplastic causes or dysplasias such as osteogenesis imperfecta. Scoliosis is very prevalent in that group, and also in multiple epiphyseal dysplasia and spondyloepiphyseal dysplasia. Other diagnoses where you can get it is achondroplasia, pseudoachondroplasia, etc. And in all of these, you need to know, is this a direct causation of the underlying problem, or is this superimposition? So when we examine patients, again, we've spoken about the gait. A full neurological examination I've placed right at the front because this may be missed if you leave it to the end, and it is very important to know the underlying diagnosis as well as to have a baseline for any management that you do. So I think we spoke about the shoulder balance, which is the relative height of the shoulders, very high or same. Pelvic balance, if there's a limb length inequality, you may get a pelvic tilt. We've spoken about the plumb line, skin markers. The Baton score is a very important test for ligamentous laxity or hypermobility. Again, typically seen in Ehlers-Danlos syndrome, where they will easily have a Baton score of 9. So this is patients who can have hypermobile joints, they can touch the floor, they can touch the forearm with their thumb. You know, this is a very well-known thing. We then need to assess the rotation parameters to see how severe the rotational component of the scoliosis is. We will come to the scoliometer in a minute. So once we have got all of this information, we want to carry out more tests to see how severe the scoliosis is, and that might be radiological. We've talked about neurology. We want to know how flexible the curve is. And in a small child, it's very easy to just suspend them to see how flexible it is. And then we've spoken about respiratory problems that may happen. So it's always good to have a baseline respiratory function. Sometimes we need cardiac function. And if you're worried about anything, you need to do the genetic testing. Any questions coming up there, Dr. Tarek? Sorry, I think you're muted.
There is a question coming up from participant is asking, kindly explain how Baton score related to scoliosis and its progression.
Sorry, what score?
Baton score.
Okay. So essentially the Baton score is scored from to a total of 9. I'm not going to go into it because we don't have the time. So the higher the Baton score, the more the patient has a hypermobility. And as I said earlier, the hypermobility may indicate an underlying diagnosis like Ehlers-Danlos syndrome or Marfan syndrome. And even sometimes you see it in neurofibromatosis. So if anyone has a high Baton score, I will send them for genetic testing, which we can see here. So that is the main relevance. I mean, if you miss a patient with Ehlers-Danlos syndrome, then you may end up giving them the wrong treatment, both surgical and non-surgical. So that's the sort of relevance of it. So this is the standard Adam forward bend test, which will give us an indication on the truncal imbalance. This demonstrates the scoliometer, which is essentially a spirit level. This is also very important because the more the apical trunk inclination, the more severe the scoliosis could be. And in some centers, they use scoliometer measurements as a surrogate for getting X-rays. So in small children with scoliosis, we want to try and avoid excessive radiation because this may cause problems in terms of cancer and all that. So there's been a lot of research carried out into what surrogate measures can be used to stop doing X-rays very frequently in children. So coming on to radiographs, the Cobb angle measurement is standard. There's some criticism that you're looking at a 2-dimensional measure for a 3-dimensional deformity, but the Cobb angle has the best long-term history and reliability, so this is what we use. The alternative, you can get x-rays with an oblique view, but this is not very reproducible. So just very simply, we have to choose the upper end vertebra, which is the most tilted vertebrae at the top, and the lower end vertebrae, which is the most tilted vertebra at the bottom. And then you draw lines along their end plates. Another way of making sure that you know the right end vertebrae is to look at the disc. So if the disc is parallel, then the adjacent vertebrae is the end vertebrae. So you then measure the curb angle directly. Now a lot of our PACS systems will give us access to the curb angle directly. So this is an X-ray showing a measurement of the curb angle. Now you may ask me, well, what is the importance of measuring a curb angle? So this gives us a baseline at the time of diagnosis. It tells us how the curve is progressing or not progressing, because progressive curves are the ones that we tend to want to treat. It is very important for serial measurements. Now it's also important to have standardized radiographs. So the standard is APN lateral, with the patients having their hands or fingertips on the clavicle. So every time the x-rays are done, they should be done in the same fashion, both AP and lateral, so it's reproducible. So in terms of management options, that then brings us to the question, how do we classify a curve? Is it a small curve or is it a big curve? So the conventional nomenclature is very variable in this situation, but the standard is any curve less than 20 degrees is small, any curve between 20 and 40 degrees is medium, curves more than 40, and I generally say to 60 degrees, can be called severe. Any curve more than 60 degrees, I just think to myself, this is really bad. And the reason for it is that the long-term natural history tells us that curves more than 60 degrees can progress after the children stop growing, can reach more than 90, 100 degrees, and at that stage, they may start causing problems. So my algorithm is that if there's a small curve, I observe it. If the curve is progressive and they fit the Scoliosis Research Society criteria, I would recommend a brace. And there's good evidence now that physiotherapy and postural exercises of any variety, the most popular I think is the Schroff technique, helps. And this has been proved as scientifically as we can by the bracing in adolescent idiopathic scoliosis trial. There is also growth control procedures that are surgical, and then we have correction and fusion procedures. I'll pause for any questions if there are, Dr. Tarek.
Yes, there is a question of here.
Yeah, go for it.
There is a few questions actually. You can go with the first question here. So if you can kindly explain regarding the correction of scoliosis, is there any effect of age on the outcome?
So that's a very important question. I think it all fits into the Scoliosis Research Society criteria for bracing. So in terms of age, we spoke about the infantile, juvenile, adolescent. Now I will, for example, speak to you about a juvenile patient. So say we have an 8-year-old girl who's got a 20-degree curve. She does not show any secondary sexual characters. She's not started her adolescent growth spurt. Now, this is a situation where I would be very concerned that when the patient enters the adolescent growth spurt, the scoliosis could progress. But I need to demonstrate that, because we also know that sometimes scoliosis does not progress. So my protocol is, in this scenario, I will see the patient in 6 months. We will repeat the x-rays or surface topography. If there is a change in the curve, as in it is getting worse, then I would seriously consider bracing. So that's where age may play a role. So if I say, for example, have a 2-year-old child who I've made very clear with all the investigations that it's idiopathic, then I will definitely brace them, because we know from the studies from Stanmore by Dr. Mehta that bracing can almost cure these curves. But at the same time, If they are progressive, then we really need to consider intervention early, because it is the young children that could end up with the thoracic insufficiency syndrome. On the other hand, if there's a 14-year-old girl who has a 30-degree curve, for example, and she started her periods or puberty a year and a half ago, then we know again from the natural history studies that this may not rapidly progress. So I would monitor them again just to see how things go until they finish growing. So age is very important, but it's also important to match it with other factors. So the Tanner grading, the x-rays of the hand, x-rays of the pelvis to see if the triradiate cartilages are open. These are all factors that you have to put together to make a management plan. Anything else?
Question, and there's multiple questions actually. And there is, and I apologize if I can't accommodate all the questions because there are many. What things should a scoliosis patient avoid to prevent worsening of their condition?
Okay. So this is something that I was actually looking into today to see what evidence is out there, because we are preparing another post on do's and don'ts for scoliosis. So really, it goes back to the theories about causation of scoliosis. And one of the theories that is difficult to really prove is the mechanistic theory. So in other words, if you load one half of the spine in an asymmetric way continuously, then we know that the growth there will be reduced and the growth on the unloaded side will increase. So for example, someone is carrying a heavy bag, and you can think the school bag on the left side all the time, and whether you're right-handed or left-handed plays a role in this. You can see that the right side is loaded and may stop growing, the left side may overgrow. So in my opinion, this is the only completely mechanistic theory that has any credibility. So looking at that, you would think, well, if you are carrying heavy school bags, don't carry it on the same shoulder all the time. You may want to carry it maybe with a rucksack so that it's equally loaded on both sides. Because if there is a familial predisposition and then you are carrying it in an asymmetric way all the time, that may cause it. Now, does swimming make scoliosis worse? Does playing football make it worse? Does ballet make it worse? Does gymnastics make it worse? There is no evidence. So my advice to most of the parents and children is be active, be sporty. And apart from avoiding a prolonged posture with one side or the other, there's really no do's and don'ts as far as I'm aware. Is that okay? Now we'll keep going. There'll be a lot of time at the end to go through all these questions again, if that's okay.
Yeah, there are many questions about management and bracing and also.
Yeah. So let me complete it, because some of these questions.
Let's continue and then at the end. Yeah, please.
But if you see something that is not covered, then feel free to interrupt.
Sure.
So we have gone from monitoring patients, and I spoke about how we do that, to the next step, which is physical therapy, be it physiotherapy, chiropractic therapy, etc., to bracing. Now, bracing in scoliosis is as old as prehistoric times. There are pictures from historical texts long ago where they have tried all sorts of bracing, right from using blood-soaked bandages. So these are animal blood-soaked bandages which are allowed to dry on the patient, and they're just left on for months, to the more modern bracing. So the most famous brace, to my eye, is the Boston brace. And this is basically a rigid plastic shell which is molded onto the patient in a corrective position. The most amount of scientific data is available for this, and there is good evidence that it works. Now, it only works if the patients comply with it, and the patients sometimes don't comply with it because it's very rigid, it's uncomfortable, it causes skin pressure problems, etc. So there have been a lot of other braces that are developed. The bracing that I have most experience with in my Sheffield Children's Hospital practice is called the spine core brace. Now, I don't have a picture of that, but it basically works on a system of belts, which makes it possible for the patients to move. They can bend, twist, etc. And anecdotally, there's better compliance with this, but the scientific evidence would show that it's not as effective as a rigid brace. So then, going along the lines of rigid braces and a combination of physiotherapy, there is a lot of interest in a variety of braces known by the Rigo brace, the Jensingen brace, the Chenot brace. These are all developed in combination with varying regimes of exercises, and there is more and more anecdotal evidence that this can provide very good control of the scoliosis. I mean, as I said, my own experience with the spine core, I've seen curves completely go away in the suitable patients. I've seen other curves being very well controlled, but I always inform patients that sometimes, in spite of the best bracing and physiotherapy practice, the curves may progress. And these are the ones that you think there may be a strong genetic link for. So we've spoken about monitoring, we've spoken about exercises, bracing. We are now moving on to surgical treatment. Now, a lot of people may be familiar with this, and the more modern therapists and practitioners may not be familiar with this. So this is the surgical treatment of scoliosis with the Harrington rod. So this was developed quite some time ago in the 40s, 50s, 60s. It became very popular, along with a lot of other techniques for scoliosis surgery, which I'm not going into. But this purely works on the principle of distraction. You attach a hook at the top, a hook at the bottom, and you ratchet it out. And I have, interestingly, seen patients 40, 50 years from surgery who are completely pleased with it. No complaints whatsoever. Now, we've not spoken much about neuromuscular scoliosis because this introductory talk, I focused mainly on idiopathic scoliosis. But surgical treatment in neuromuscular scoliosis has again undergone an evolution, and every surgeon has his own philosophy. So this is a patient who in sitting has a 75-degree curve. They've had a staged attempt at scoliosis surgery. You can see the markers which show they've had multiple discectomies and anterior fusion attempt. They're then in a brace, and at the second stage, they've had posterior fusion with, again, you can see the cages, and you can see a very good correction. Now, in the neuromuscular scoliosis, the main aim of surgery is a pain-free, balanced spine that is easy for patients to sit, for wheelchair adaptations, etc. So this is again a slightly earlier version of a posterior only instrumented correction. You can see that there are not many screws or instruments in the apex because it was thought to be very high risk. There is what we call a hook in a claw type configuration at the top. There are pedicle screws in the lumbar spine, and there are some hooks in the convex side. And you can see here the concavity is treated with sublaminar wires. So these are wires passed under the lamina and twisted around the cord, which were felt to be much safer than putting pedicle screws into the apex. Now, the current state of the art is we would instrument the spine in a pattern with screws throughout with segmental fixation connected to two rods. And that gives better control of the apex and a better derotation. But as I've said to you before, the patient satisfaction with from a Harrington rod onwards with surgical treatment has been very high. Now, we talked about age and how this may affect our treatment. So this is a nearly 80-degree curve in a 7-year-old patient who's very skeletally mature. And you can see that this type of curve can be quite progressive when they enter the adolescent growth spurt and could easily reach 100 and 120 degrees, which can cause cor pulmonale or cardiorespiratory problems. And this shows the patient being treated with a growing rod system. So this is a proximal anchors, distal anchors. We have not touched the intermediate part of the spine except for distraction. and then this part of the construct can be distracted and accommodate for growth. Now, this type of construct, once the patient has reached 13, 14 years of age and has crossed the rapid growing of the chest, then we can do a definitive fusion. So I often tell patients this is stage 1 of a two-stage procedure. Now, if you ask me what is the more recent and exciting development in scoliosis surgery, I would be remiss if I did not talk about vertebral body tethering. Now, interestingly, this goes back to a long time ago when staples were used anteriorly to try and stop the growth of the convex side of the curve. This is the more modern, if you like, vertebral body tethering system. This can be done through thoracotomies or through thoracoscopic approach. You can see this patient has a chest tube, so may have had a thoracotomic approach. This is a picture from the file. I have not yet embraced this technology, but I'm looking into it to see if this can be carried out safely. There are other growing spine technologies, one of which is the ApiFix, which is applied to the concavity of the curve. So you fix a system to the concave side, and it's a dynamic system so that each time the patient moves away from the concavity, the implant grows, and then it does not collapse, so their spine gets straighter. So there are a lot of newer techniques coming up which need to be very carefully looked into and analyzed to make sure they're efficacious whilst having an acceptable complication rate. Before going into the discussion, I will see if Dr. Tarek has any more questions for us. Dr. Tarek?
Yes, I'm here. I'm just looking at the questions. Well,
just pick out any question.
This is an interesting question. Is surgery indicated for osteoporotic spine with severe curves?
So again, this is what I would consider an advanced topic. And in fact, I recently attended a webinar on this. So it's very unusual to have an osteoporotic spine in children, even though with the low vitamin D, you can get rickets and osteomalacia. So the osteoporotic spine is a problem in adult spinal deformity. Now, I've deliberately stayed away from it for this webinar, but seeing as it's been asked, we'll go into it. So adult scoliosis, there are two types. The first type is an idiopathic scoliosis, which developed in their early years. It's been treated non-operatively, and when they are 50, 60, 70, with the advent of degenerative changes, this has started becoming symptomatic. The second type is what we call de novo degenerative scoliosis. Now, this arises in a completely straight spine, we think, but due to the purely asymmetric nature of the degenerative changes, they develop a scoliosis. So there are two scenarios here, and both of these may be complicated by osteoporosis. Now, surgery in this group is very much a balancing act. You look at the risks of surgery, you look at the problems the patients are having, and you look at the benefits of surgery. But in brief, I will not say to a patient, you cannot have surgery because you have osteoporosis. I may want to optimize them by treating their osteoporosis. There are very successful treatments for osteoporosis. And during the surgical technique, we would use strategies that allow us to tackle the osteoporosis, which basically may be with the use of augmented screws. It may be with the use of vertebroplasty, and being a little bit more careful with how much correction you wish to achieve. I hope that's answered the question.
Thank you. So there is another question regarding, I think it's also, it needs another lecture for advanced people with...
That's fine. I think we have some time to go into the advanced part of it.
Okay. So any comprehensive articles on link is rule breaker and selection of UIV and LIV in adolescent idiopathic scoliosis.
Yeah, so the UIV and the LIV, for those who are not familiar with these terms, is the upper instrumented vertebrae and the lower instrumented vertebrae. So there are lots of theories. Every surgeon has his own philosophy as to how they select the upper instrumented vertebrae and the lower instrumented vertebrae. What we are striving for more and more is to keep the levels of fusion as short as possible, at the same time giving the best correction and preventing what we call an adding on phenomenon. So the standard teaching is you draw what's called the vertical line in the central axis. So the central sacral vertical line. And you want to try and find out the stable vertebrae and the neutral vertebrae. So these are vertebrae that touch the central sacral vertical line. You also need to know where the apex of the curve is and where the end vertebrae are. And depending on how brave you are, you may want to, for the really brave people can go cob to cob. So the vertebrae you use to measure the cob angles. So in a right thoracic scoliosis, you may want to consider fusing from T5 to T10. But the more conventional teaching would be to say, go from T4 to T12 or T3 to L1. We also look at the shoulder balance and the trunk, the waist balance. So if the shoulders in a simple right thoracic curve, the right shoulder should be high. If the left shoulder is high, it means they may have a double curve or a type 2 curve. Again, looking at the lumbar symmetry or the waist symmetry, we want to know whether the lumbar curve, which is compensatory to start off with, has become structural. If it has become structural and there's a significant waist asymmetry, then we may want to go further down. So as Dr. Tarek said, this is a webinar in itself. So I'm more than happy to be contacted, and my contact details will be on the last slide on a personal level to discuss this. But I don't think we can go any further for this question in this webinar. So next
An easy question. What is the recovery from surgery like?
So recovery from surgery, I will take a typical patient. In fact, the one that I have coming up. So this patient has a 65-degree right thoracic curve. The proximal thoracic curve and the lumbar compensatory curve are what we call non-structural according to the Lenke classification. And again, I've not gone into the Lenke classification on this session, you would have noted. So in this case, I'm treating it as a type 1 curve, and I'm fusing from T3 to L1, which is being a little bit generous and maybe a little bit timid in some people's opinions. So this patient, I would typically expect that the surgery takes about 5 hours of surgical time, because I don't believe in rushing surgery. The patients are in hospital for about a week. Once they leave the hospital, my advice is that apart from sitting, standing, walking, lying down, they do not do anything else for 8 weeks. I generally see them at 8 weeks, get some x-rays or radiographs, and if I'm happy with it and the patients have recovered very well, I will say, well, you can do more. For example, I would say if you are swimming, then spend more time in the pool. You can slowly get back to swimming. You can do aerobic exercise, but nothing that twists the spine particularly or does repetitive bending and straightening. This goes on till the 6th month. From 6 months onwards, I would say, well, if you like doing ballet, for example, you can go back to doing a bit of training. And as long as symptoms are not too bad, they can progress. If you play football, you can go back to training in football. But the really heavy, strenuous contact sports, for example, rugby, I would generally recommend that they train for it, but only do it competitively after 12 months. So you're looking at a 1-year recovery period. Anything else?
So another question, is there any concept of removing the prosthesis after fusion?
So I have never removed an asymptomatic fusion implant. The only situations where I've been back to removing them, one was an instance of an infection, surgery done elsewhere. The patient, we tried multiple doses of antibiotics, the infection kept recurring, so we went in and took out all the implants. And interestingly, 90% of the rods, screws, the rods and the screw heads were covered by bone. There's only 10% which was the focus of infection, which was free of bone. So we spend a lot of time chipping away the bone to get the implants out, because we decided to remove all the implants. So the aim of the fusion is that the implants are covered by bone, essentially. And we use a lot of bone graft from the local bone, the spinous process, the lamina, the transverse process, and literally cover the whole part of the treated spine. So in this situation, there's no need to remove the implant in the first instance. Removing implants does not solve any symptoms that the patients may have. So for example, if patients are having a painful area, I would do a CT scan. And if there is any obviously loose or prominent metalwork, we could remove it. But we do not, as a routine, recommend removal of all the implants.
Thank you. Another question, how to measure anatomical variations in scoliosis compared to normal bones?
So is that about anatomical variations in the bone density or curves?
Well, he did not emphasize on which one.
Okay, so, well, anatomical variations are the norm in scoliosis. There is no single scoliosis type. For example, in the Lenke classification, there are 6 different curve types. So you can have a single thoracic curve, you can have a double thoracic curve, you can have a thoracolumbar curve, you can have a thoracic and lumbar curve, and you can have a triple curve, which is a double thoracic and a structural lumbar curve. So there are lots of variations. I'm not sure if that was exactly the question, but if not, again, get in touch and we can clarify for you.
Yes, yes.
So any more questions? We've got 10 minutes, so we've got plenty of time for questions.
Yes, regarding what? So you have mentioned about scoliosis and muscular atrophy or dystrophy. What's the relation in this?
Okay, so there are actually 2 different groups. So muscular dystrophy, the most familiar might be Duchenne muscular dystrophy. So this is a problem wherein patients have an inborn error of the way the muscular molecules behave. So the muscles do not function as normal. And in Duchenne, for example, typically they have hypertrophy. The calf hypertrophies, there's the so-called inverted champagne bottle appearance of the calf. The patients generally have weakness. They can't do any sustained activity. And there are multiple different types of muscular dystrophies. There's the Becker, the Spar, the Schmidt, etc. So the problem in this is a different muscle balance. And because the muscle balance is not normal, the children slowly lose the ability to walk very rapidly. They are in a wheelchair, and traditionally the wheelchairs may not have had very good trunk support. So because of this, they may have been sat for long periods of time like this. And they typically develop C-shaped curves. These can become rigid and progressive. They can cause what we call costopelvic impingement, where the rib cage impinges on the pelvis and can become very painful. So in these patients, we may have to consider surgical treatment. They are high risk because this also affects their respiratory muscles and their cardiac muscles. So we have to be very careful. There needs to be a multidisciplinary team approach to managing these cases. Spinal muscular atrophy is an inherited abnormality, again, of the musculature. There are various different types, SMA 1, 2, 3, and then more being added as we get more information. So this, again, is similar in terms of the causes for the scoliosis. Obviously, the etiology of the condition is different. It's very important to distinguish them because the spinal muscular atrophies are now being treated with intrathecal injections of mucinersen, which helps the neuromuscular junction. So there is potential for controlling the severity of the disease. So a lot of syndromes can have muscular problems. A lot of syndromes can have abnormal vertebral development. One of the typical ones is called the Vactal syndrome, where you can vertebral abnormalities associated with tracheoesophageal problems, cardiac abnormalities, renal abnormalities, etc. Does that make sense?
Yes. So, one more question. What is the incidence of scoliosis in terms of levels of the spine?
So, I mean, if we differentiate into cervical, thoracic, and lumbar, by far the most common is the thoracic spine. Now, I cannot give you numbers, but in my practice, if I do 10 operations for right thoracic scoliosis, I will do 1 operation for a left thoracic scoliosis. I will come to that in a minute. And I will do 2 operations for a lumbar scoliosis. For a cervical scoliosis, I have never operated on for an idiopathic variety. So there's always some sort of a congenital abnormality which causes a cervical scoliosis. Now, the reason I was speaking about the right thoracic and left thoracic scoliosis is because the typical adolescent idiopathic pattern is a right thoracic scoliosis. So if you see, for example, a 12-year-old girl with a left thoracic scoliosis, that should start ringing alarm bells because there may be an underlying problem. So we spoke about MRI scans briefly during the assessment part of this talk. So my practice, I believe in my own clinical acumen. So if I have thoroughly examined the patient and I'm happy they have normal neurology, I don't routinely carry out MRI scans. I would be happy to just monitor them. But if there is any abnormality on neurological examination, they will get an MRI scan. Everybody gets an MRI scan before corrective surgery. But if I see, as I said earlier, a 12-year-old girl with a left thoracic curve, even if the neurological examination is normal and everything else is normal, I'll get an MRI scan because it's an unusual curve pattern. And I've often picked up diagnoses like syringomyelia and other issues with these MRI scans. The other reasons while we're on the subject for getting an MRI scan is if there is a particularly painful scoliosis, because we know that scoliosis per se can be divided into a positional, functional, and structural scoliosis. So positional basically means if I'm sat like that and get an X-ray, I'll have a curve in my spine. The functional, again, is people that it might not be the most correct terminology, more an antalgic scoliosis, because there are conditions like spinal infections, osteoid osteomas, or other types of spinal tumors, which can cause scoliosis due to the pain and the muscle spasm. And then you have the structural scoliosis where there is a rotation in the spine causing the scoliosis. The antalgic scoliosis, actually sometimes when you scan them or do x-rays, they may actually not have a curve in the spine. So it's more a muscle spasm related curve. I hope that answers it to an extent.
Well, thanks. One more question. With the current surgical implants and techniques, what contraindications would you advise a physio post-op? How limited would be the patient's range of motion be?
Okay.
Any special indications?
Okay. So I think basically the question is, how do we rehab patients after surgery? And are there any particular do's and don'ts in that situation? Okay, that's how I'm going to answer it. So as I said, my scoliosis protocol, predominantly for 2 months, we don't do any physiotherapy. The role of the hospital physiotherapist is to help the patients mobilize, make sure they're safe standing and walking. They know how to sit, they know how to lie down, they know how to get off of a bed. From 2 months onwards, I get more input from the physiotherapist. So we talked about shoulder balance in scoliosis surgery, and this is one of my pet research topics about how can we monitor shoulder balance. So the traditional conventional right thoracic scoliosis will have a right shoulder high, and when we do surgery, we try and level the shoulders. Sometimes after surgery, because of maybe a more enthusiastic correction, the left shoulder may go high. But this is all in the flexible, non-fused part of the spine. So I get the physiotherapists to train the patients with balancing, gait, and specific exercises aimed at treating this. Range of movement, amazingly, is not particularly affected by fusing the thoracic spine. They can still almost touch their toes and do most activities I've had patients return to gymnastics, return to playing tennis, return to high-level swimming, etc. So we're reaching the end of time. I'm just going to finish my talk, and then we can see if there are any other questions. So scoliosis produces trunk asymmetry in mild, moderate, and severe cases. And that could be classed as maybe just a cosmetic issue. In severe cases, we can affect cardiorespiratory function, causing cor pulmonale. So my theory is that early diagnosis and appropriate management will reduce curve progression and possibly avoid surgery, as we've seen in the braced trial. So bracing and exercises work as long as they're done correctly and the compliance is good with the patients. In progressive curves, we may have to consider surgical treatment, especially the infantile and juvenile types. So this is just a rehash of the same thing. There are lots of references. If you Google scoliosis, there are thousands and thousands. And we've come back to this slide in a minute. So I thank you all for taking this time out of your busy schedules to attend this webinar. We are always happy to receive questions, contact regarding scoliosis in general. If you want to discuss with me and the team regarding a particular patient, there is my email address. You can always contact the hospital through the switchboard, the website, and all inquiries will be forwarded to me if it's in relation to scoliosis. So we'll take questions for another 5 minutes, and then I think we may have to let people go back to their evening. Any other questions there, Dr. Tarak?
So I have this question regarding, the braces or bracing for patients with syndromatic scoliosis. Are they different from the other patients with adolescent idiopathic scoliosis?
Yes. So the role of syndromes in scoliosis have to be very carefully analyzed. It is possible that they have an adolescent idiopathic or early onset scoliosis superimposed on a syndrome. But having said that, most of the scoliosis that we see in syndromes are related to the particular syndrome. So the conventional belief is that bracing does not work in syndromic and neuromuscular scoliosis. But as with everything, there are exceptions. In early onset or in really young children with syndromic or neuromuscular scoliosis, I sometimes brace them to control the curve until they are old enough for surgery. So if, for example, I see a child who is 5 years old with a neuromuscular scoliosis and they are low tone, in which case their scoliosis is flexible, then I would prefer that we control the scoliosis with physiotherapy, hydrotherapy, bracing for as long as we can, because these children, ideally, I want to operate on them when they're 12 or 13. Now, sometimes in spite of the best efforts, the curves can progress, which is where we then start talking about the growth control type of surgical treatment. So it may be with the magnetic controlled rods, it may be with the conventional rods, it may be tethering, which again is not proven in neuromuscular scoliosis, or it may be with the distraction type techniques. I hope that makes sense.
Thank you. I think we're coming to the end of this interesting session. I would like to thank you, Dr. Michael, and thank everyone who attended our session, and hopefully to see them again and or to hear from them again. So by tomorrow, we can send you the forms, evaluation forms, that you can fill it up and send it back. And those who attended the session, they can receive the certificates, CPD, yeah, for 1 hour in the coming few days. Thank you, everyone, and hope to see you again.
Bye. Have a good evening.